Now, let me just put up this quote from Bertrand Russell. It's about 100 years ago. If a man is offered a fact which goes against his instincts, he will scrutinize it closely, and unless the evidence is overwhelming, he will refuse to believe it. If, on the other hand, he is offered something that affords a reason for acting in accordance with his instincts, he will accept it on even the slenderest of evidence. The origins of myths can be explained in this way. I think this applies to the prostate cancer screening argument. So, we published the PLCO trial 3 times, most recently about last year in Cancer. The results have not changed. There is no mortality, prostate cancer specific mortality, or definitely overall mortality benefit to having PSA testing now for a median of 15 years of follow-up. There are many well-known limitations of the PLCO trial. Let's be honest, there was a lot of pre-screening. A third of the patients were pre-screened before they were randomized. During the 7 years of screening, there was only 85% compliance in the screened arm, 42% contamination in the control arm. So it's a trial of a lot of screening versus a little bit of screening. Now, after the screening period ended, which was just 7 years, contamination rose steadily. And I would point out, though, that notwithstanding the ongoing contamination, and I'll show you the graph, the number of cases discovered in the screening arm is about twice the number of cases that was discovered in the control arm. So it reduced the power to detect a difference, but not invalidate the trial. And another limitation is that we had a very healthy group of volunteers in the PLCO cohort. The overall mortality was only about half of what we anticipated it would have been when we designed the trial in the early 1990s. And here is some of the contamination data that were recently published, and you can see that most of the excess contamination occurred after screening, but as I said, it didn't really change the proportion of cases of cancer diagnosed in the control and the screening arms. Here is just showing that not only was overall mortality less than we anticipated, but prostate cancer-specific mortality for all groups, screened and unscreened, was only about half of what we designed it to be. Now, those are the well-known criticisms of PLCO, and there's others. But I got to tell you, most of the other criticisms are completely inappropriate. You'll hear it all the time, that there was a low biopsy rate or a delayed biopsy, and that this missed the chance for cure. Well, that's not really true, because if you look at the PLCO trial, notwithstanding that a third of the patients were pre-screened, at 12 years of follow-up, we actually had a higher incidence of prostate cancer in PLCO than there was in the European study. And remember, we used a PSA threshold of 4 in PLCO. ERSPC used a PSA threshold of either 2.5 or 3. So we found more cancer in PLCO than was found in the ERSPC. So you can't say we weren't looking for cancer or trying to find it. And the other thing that's true to say is that the mortality rates in PLCO for both arms were significantly lower than the prostate cancer mortality rates in either arm of the ERSPC. So you cannot say that this was a bad study for that reason of a low biopsy rate. Now, what about the European randomized screening trial? The corpus of the data have been published 2 times, and you can see the references here. I want to point out there's substantial differences between PLCO and ERSPC. I've highlighted in red the most significant ones. The type of randomization, totally different. Population level in ERSPC versus individual in the United States. And finally, where the evaluation and where the treatments were administered. In the United States, they were done in the community. In the European study, they were done at large centers where the patients who were invited to be screened showed up to have their PSA and had their biopsies, and then they had their treatment. And this has an impact on the outcome. Now, for ERSPC, the limitations are much less well known, especially among urologists. There were variable screening protocols, and this was first pointed out by Peter Boyle and Otis Brawley in 2009, and more recently in a large review in the British Medical Journal just last year, that there were so many differences among the screening in the different countries that they think the analysis, the way it was analyzed, is not appropriate. And the other thing that's really getting a lot of attention now is that all the data of PLCO and most of the large trials done in the United States are publicly available. Anybody can get it. Anybody can analyze it. ERSPC refuses to do that. And that causes people to wonder, could this be the best way to analyze the data? Is there not another way to look at the data? I really can't comment on that. Another major concern, the mortality reduction was seen only in a core group of patients. It was not seen in all men who were randomized, and all of the countries have not yet been included in the overall analysis of the ERSPC. Finally, the significant mortality reduction was seen in only 2 of the 7 countries that were reported. And if you remove either one of those countries from the report, it becomes a negative trial. And here's the forest plot that the U.S. Preventive Services Task Force used, and you can see that Sweden and Netherlands showed positive results and the other countries did not. The big problem here is Finland. And why is Finland a big problem for the ERSPC? Well, the Finnish arm of the ERSPC was slightly larger than PLCO, and it is the largest component of the ERSPC. Notice there's a lot of deaths from prostate cancer in Finland, 3 or 4 times as many deaths as there were in the United States, so there were potentially more endpoints you could get to. But notwithstanding that, PLCO and Finland were both negative for the impact of screening on prostate cancer mortality. Now, everybody says, well, what about Sweden? Sweden is the smallest arm of the ERSPC. Like Finland, it has a relatively high proportion of deaths from prostate cancer. You can see it's about 1/4 the size and the number of men enrolled, about 1/4 of many prostate cancer deaths. And that did show a substantial risk reduction for dying of prostate cancer. Now, let me ask you a question. If you had 2 studies, one that was 4 times the size of the other, and the small study showed a benefit to something, but the larger, 4 times the size study did not show any benefit, which one do you think you're more apt to believe? Which one is more likely to be telling you the truth? I'll just ask you to think about that. Finally, there are substantial treatment differences in the ERSPC. This was a paper published in 2010, doesn't get a whole lot of attention, statistically significant for each of the intermediate, low risk, and high risk prostate cancer groups. I'll just look at the high risk prostate cancer group. Screened men were twice as likely to get a radical prostatectomy as men who were in the control arm. On the other hand, the control arm men were twice as likely to get only hormonal therapy. These are substantial treatment differences. This was true in Gothenburg. Unscreened men were 3 times as likely to receive only androgen deprivation therapy and half as likely to get a radical prostatectomy. How about the Netherlands? For the high-risk men with localized disease, screened patients more than twice as likely to have a radical prostatectomy. Control patients more than twice as likely to get only hormonal therapy. Treatment matters. We heard the criticisms of the PIVOT trial earlier. Furthermore, treatment location difference. There were significant differences. If you were randomized to screening, you were 6 times as likely to get biopsied and treated in a major academic center. And for that reason, you may have had a better radical prostatectomy. You may have had better radiation therapy. You may have had more aggressive treatment by your medical oncologists and the like. These are substantial differences that matter. Now, here are the data that the U.S. Preventive Services Task Force looked at in 2012. You can see that after about a decade of screening, they said, well, maybe 0 to 1 man's life would be saved. And you're right, this was revised. This is the draft cartoon, which now says after 15 years, maybe there's 1 or 2 men out of 10,000, out of 1,000 screened for 15 years whose life would be saved. So it's not a very, very large effect. Late last year, we published a paper trying to reconcile the effects of screening from ERSPC and the PLCO trials, even though they were substantially different. This is way above my pay grade. Ruth Etzioni is a very, very smart woman. She did all of these micro-simulated models and whatnot, and she says, okay, there could be a 25% benefit to getting screened. And here are some of the curves they have. But what I want to point out to you is that when you look at the y-axis of this graph, it goes from 99% chance of not dying of prostate cancer to 100% chance. All of the differences is somewhere between 99 and 100%. the magnitude of the difference is very, very tiny. So I would put it to you that PSA-based screening, as we've been doing it, is suboptimal. Now, if you don't believe me, and I'm sure you don't, you could turn to Twitter, because in preparation for the ASCO-GU conference that's going on right now, there was a dialogue on Twitter. Urologists could participate, medical oncologists, epidemiologists, and the like. Now, let me just show you some of the comments, and this was 2 days ago on Twitter. PSA screening does not improve mortality in randomized trials, period. In some trials, it improves a low-quality, disputed endpoint called death from prostate cancer, which requires provider, researcher adjudication, which is not an exact science, and ignores off-target death. PSA screening improves death from prostate cancer in some trials, notably the large European study, but not others, and in that trial, only in some nations, but not others. Not exactly a robust finding. Proponents of PSA screening fault the negative PLCO trial for contamination, which occurred higher than initially advertised, but this is disingenuous because despite the contamination, there was excess. There was twice as many prostate cancer cases in the screened arm. In contrast to the European study, the PLCO was a much better run trial. It had rigorous endpoint adjudication and case auditing. Look at the trials closely. The European trial is a hodgepodge of different trials. It is really a bad meta-analysis. Garbage in, garbage out. That's what GIGO means. Meanwhile, the harms of PSA are massive. They include overdiagnosis. Even in the positive European trial, 27 men had to have been detected and have local therapy to avert one poor quality endpoint disease-specific death. This is insane. Bottom line, if someone just developed a test like PSA, and if the FDA regulated screening like they do pharmaceutical drugs, then rest assured there is no way in hell an intervention with this poor harm-benefit ratio will gain approval. Accepting the truth regarding PSA would destroy entire specialties and practices that subsist off the cash from referrals. But this does not explain the full recalcitrance. The biggest form of poor thinking is thinking that taking care of prostate cancer patients helps one understand screening. No, sorry. Understanding cancer screening and public health is the only expertise that matters. It's a different skill set entirely. It requires a different skill set to understand screening, and I cannot bear to listen to any more people pretend that treating local cancer somehow gives them a perspective on screening. In short, PSA screening has a poor risk-benefit profile, serious harms, overdiagnosis, no proof of improving all-cause mortality, and improves disease-specific mortality in some but not all trials. It's a total public health disaster. Most people you perform PSA on, including those who have what is called cancer by histology, do not and will not have a disease. So listen, that's very inflammatory. I know it makes everybody sad. I don't think we should throw away PSA. I think we should make PSA great again. And I think there's 4 ways of making PSA great again, and they're right within our grasp. First thing, test the men who need to be tested. Just testing them because of age is bullshit, bad, awful, not good. Here are the NCCN guidelines from 2017. And it talks about on that leftmost thing, and this is the draft so you can see the differences. Men who have a genetic predisposition to cancer. I was a participant in Philadelphia at what's now referred to as the Philadelphia Prostate Cancer Consensus Conference, and our paper got published in JCO late last year. Here are the take-home. Which men should consider genetic counseling and genetic testing? And you can see the degree of agreement among the people participating in that, and you could read that box for yourself. Which genes should be tested if you're going to test these patients? You can see there which genes should be factored into management considerations, and you can see them there. Consider reflex tests if PSA is abnormal. Don't rush to biopsy. I like the 4K test. I think PHI would perform the same way. Here are some data from PROTECT showing that you could reduce the number of unnecessary biopsies by about 40% We did that in PLCO from our archive samples, 37% reduction in unnecessary biopsy without missing any significant cancers if we did not biopsy men who had less than a 5% chance of cancer on the 4K assay. Second thing, do a quality biopsy. We've heard it here, and I think it's true. Random office trust biopsy is not the best biopsy. This paper, the transperineal precision point paper, came out like last week in the Gold Journal. I've been doing some of these transperineal biopsies. Roberto talked about it earlier. I really think we got to get away from the transfecal office biopsy. The other quality biopsies are to do MRI. We heard a lot about that. MRI is not perfect, so I biopsy other parts of the prostate if the MRI is negative. We have a lot of good data, as do others, showing that MRI is more likely to find a significant cancer and less likely to find a trivial cancer. I think we're entering an era where we may get away from biopsy altogether, particularly as we explore more about PET MRI, and a lot of the things that are going on at my medical center and others, and it could be that this discussion of biopsy is going to be silly. Fourth thing, you have to avoid overtreatment. Remember, in the NCCN guidelines for very low-risk Gleason 6 prostate cancer, you shouldn't even think of treatment unless the man has a 20-year expected survival. If he has low-risk disease, then you could draw the line at about 10 years disease. And we may have some genetic tests that will allow us to decide better who needs to be treated. You're familiar with them, the Decipher assay, Oncotype GPS, the Prolaris test, and the ProMark, and you can see the comments from the NCCN guidelines panel. So screening, where do we stand? I think if we keep doing the same thing that we did in PLCO and ERSPC, screening will never be shown to be effective, and it'll never be embraced by people who are public health sciences and the like. 4 things we can do to make ERSPC and PLCO irrelevant and to make screening a lot better. Screen the correct men by age, family history, and genetic predisposition. Use reflex tests to avoid unnecessary biopsy. If a biopsy is warranted, do a quality biopsy. I used to call the office transrectal biopsy a hand job biopsy, but they said that wasn't politically correct, so I'll call it a hand-done 12-core biopsy. I don't think they're any good. And finally, if cancer is detected, we've got to consider whether to treat, and we should consider using some genetic tests to assess for degrees aggressiveness. So thank you very, very much.